but it's really important to, sorry, can we share the screen please? ممكن نشير السكرين لو سمحت? Share the screen here. But it's really important for everyone to recognize our problem. When we're defining the problem, we can get solutions for our problem. So our topic will be about challenges and opportunities for brachytherapy and radiotherapy in our middle and low-income countries. As I said, when we have a problem, we should first define your problem. You should first define your problem to get a solution, to get a better solution. You should know the amount or the capacity of your problem so you can get solutions for this. So what's our problem actually? So here in Africa, cancer is one of the dominant causes of death. Actually, it kills more people, more than HIV, more than TB and malaria, all together. So the question is, what's the impact of this? What's the impact of this mortality on children and on the population? Here is a very interesting study or module, I think it's a US module, estimating the child mortality associated with the maternal mortality from breast and cervical cancer. How can the mortality of the mothers impact the children in Africa? And actually the conclusion was really interesting, that for every 100 women who die from breast or cervical cancer, between 14 to 30 children will die from any other causes, just because their mother died or they lost their mother, especially in children less than 10 years. So for radiotherapy and brachytherapy, actually it's a very essential component in treatment of gynecological cancers. It's one of the curative components. Due to shortage of the brachytherapy machines in many institutions in the middle and the low-income countries, some thought about replacing brachytherapy with other modern external beam technology, but actually it proved to be inferior and to get a suboptimal results. So brachytherapy is still one of the most important components of treatment of gynecological tumors. So first, let's identify our problem. The first point is about availability. Let's see this. This is to imagine how far we are. This is the USA radiotherapy facilities, where we have one machine per 640,000 people, while here in Africa, it's one machine per 4.8 million people. So can you imagine the disparity between both? There's another important example actually here. Here's the distribution of the radiotherapy facilities all over Africa. We can find those with the blue color have the highest capacity of radiotherapy facilities. South Africa, Egypt, Tunisia, and Morocco. While the other countries, some countries are lacking even only one linac. So let's have this example about Nigeria. We can see this, I chose Nigeria because it's one of the highest population density actually in Africa. So Nigeria has, I don't see if the numbers are clear or not. Here in Nigeria, we can find that the population is 206 million people, 206 million population. So how many linacs serve those? Only 7 linacs serve 206 million people. Let's have another example, Switzerland. For Switzerland, there is only 8.6 million people and served by 72 linacs. Again, there is a huge disparity between high and low middle income countries. So out of the 54 countries in Africa, there are 52 countries considered to be low and middle income countries by the World Bank. 28 out of the 54 lacks any radiotherapy services, any radiotherapy machines, whether external beams or brachytherapy. We can find also that 70% of the brachytherapy units are only located in those 5 countries: Algeria, Kenya, Egypt, Morocco, and South Africa. So we can conclude that here in Africa, there several countries are struggling to offer brachytherapy as a routine treatment for gynecological tumors. Let's go for our home country, Egypt. Actually, in Egypt, we are moving on very quickly, since the many regional cancer centers, university hospitals, and NGO hospitals started to implement the HDR brachytherapy. In the last couple of years, actually, we have more than 5 new HDR machines implemented here in Egypt, all around Egypt. So after a long waiting list of brachytherapy reaching up to 4 and 6 months, where the patient finished her external beam and wait for a few months to receive her brachytherapy, now Egyptian females have gotten access to nearby HDR centers. So we finished our first topic. It's our first problem. It's the availability. Our next problem that we should face is the human resources and training. To deliver brachytherapy and a good brachytherapy service and a safe brachytherapy service, this demands a very specialized training to both oncologists and the physicist. So what's the program we need to apply? So we have 3 sectors, important sectors, that we should apply in our training programs. First, lectures and academic lectures concerning the radiobiology of brachytherapy, the difference in the radiobiology between external beams and brachytherapy. Secondly, and it's very important, the hands-on skills and training on the handling and the insertion of the applicators, whether the intracavitary ones or the interstitial ones. This is a very important section training. And last here, you should be well trained on defining your target volumes, on defining your organ at risk, and on defining the doses you need to give to the patient. This would be our last slide for the physicists. What should the physicist be trained to be well qualified for brachytherapy? First, there's a sufficient on-site training on brachytherapy dosimetry, and this is very important. Here in Egypt, we used to have low-dose rate machines in many centers actually here in Egypt. So as an oncologist, as a physicist, we are familiar with low-dose brachytherapy, but we still need an experience in the high-dose ones. The second important is the afterloader procedures, and the QA are required. Lastly, training on radiation safety and HDR emergency. This is my last slide. So what to do? It's better to start with the simple treatment planning methods as a fixed geometry or library plans. This is very important when you start to implement a new HDR machine at your institute. So please don't start with a complex treatment. Don't start with the complex treatments. Just start with the simple 2D treatments, applying to point A, and then upgrading your physics experience to go for a complex treatment. And thank you. I will give the mic to my senior and to my friend, Dr. Ghada, to continue this session about the implementation of the HDR in Ain Shams University. Thank you.
Hi, everyone. And to go directly to the next slide, I am proud to be a part of the Al Demirdash Hospital. It's one of the first university hospitals established in Cairo, 1928. But actually, the Faculty of Medicine is 1947. And I am part of the clinical oncology department that have radiotherapy long years ago, but actually the brachytherapy unit, as in other institutes in Egypt, there was a 2D far away from many years, and now we are launching from 2021 the brachytherapy unit in a very hard circumstances, actually in the COVID era. We faced the problems in everything, in importing of important devices, in training and anything and everything, and till our fully theater was ready. So this is our theater. So it have anesthesia machine, ultrasound, lithotomy bed, recovery room, steam sterilization. We started for 1 year, about 1 year, with just vaginal vault brachytherapy. Then we started the operative theater and the intracavitary and the interstitial also. brachytherapy in this March 2022. So about the clinical implementation, it's important, as my dear colleague mentioned, the availability of the machine, then the training of the staff, and then there is very important topic is the clinical implementation and the flow of work and the organization of the flow of work, and there's a fixed SOPs or standard operative procedure which is known by all the team, the doctors, the physicists, the nurses, and the technicians. It's simply like this flow chart is starting where, who and when to start a specific part of the whole procedure. It's simply who will do what by when. So all the steps should be discussed by all of our team and to be as a dry run before the delivery of the first treatment. So it's very important to say that is all that the achievement so far. It's so little achievement, but it's great for us. Will not be done without our mentor, Dr. Huda Al-Bouz. She initiated our work in the unit. We are working with her guidance, periodic case discussions and on-site visits, weekly online meetings, and continuous guidance and advice, and we would like to thank her very much. So another topic is, oh yes, it's my dear Christine slide. It's all die like a pie. Another very important topic we have to mention that we faced actually when we implemented the brachytherapy and started especially the intracavitary and the interstitial cases, the poor referral system. So we have a problem in that the patient is referred after maybe 2 months, maybe 1.5 months. It is not referred in the optimum timing. Many times, especially in some centers, a few centers outside Cairo, that there is no available extra beam data, which is very important to have before starting the brachytherapy, especially if the patient received the boost on the lymph nodes by IMRT, and to maintain a good follow-up with the patients, especially if they are referred from far away and going back. We have to continue follow her up if she is even a private case, to establish a fixed follow-up procedure. You should come, we tell the patient, whenever you are coming from, we will come after 2 to 4 weeks for examination and assessment of toxicity. You will do your first MRI in 3 months, and you are in contact with at least 2 of us to mention if there is any problem or any inquiry she wants to ask for. And finally, we should introduce the Indian inspirational example. In India, many regional cancer centers like Tata Memorial Center in Mumbai and All India Institute of Medical Science in New Delhi are improving the cancer treatment facilities by development of centers in the rural areas, providing greater access to brachytherapy. And also, there's parts like organizations like Association of the Radiation Oncologists of India and the Indian Brachy Society that are engaged in training workshops to promote the brachytherapy practice. And our Indian mentors that we're very lucky to be a part of this team for 2 weeks. The Human Cadaveric Hands-on Brachytherapy Workshop in India, conducted in Ramaya Medical College and Hospital in Bangalore. Thanks for them very much, and thank you very much for listening.
Thank you, Professor Ghada and Professor Christine, for a nice and informative lecture. We will go if there is any question.